Thank you, Stephen. Thank you, everyone. Thank you, Caroline, for being here. Caroline is currently in Norway, in Bergen. And apparently her view is absolutely fantastic. So thank you for joining us today. Let me just set the stage for Caroline. Later on, we'll share top 10 insights into citizen and patient engagement in Canada. For those of you who are familiar with public patient engagement, citizen engagement, with what's happening in terms of research and policymaking in Canada, you probably know that the last decade has been really the patient engagement and the partnership era. So there's been an increasing worldwide attention to engaging patients in various health system domains, engaging patients in their own care, in quality improvement initiatives, at the organizational level in planning programs and services, but also at the policy making and making a very difficult coverage decisions and coverage policies. We've seen also patient engagement in very technical areas like health technology assessment. So many HT agencies in Canada, most notably CADIT and Health Quality Ontario, has been doing a lot of very promising work in terms of patient engagement. And in the past couple of years also, we've seen the field of research opening up to patients with the strategy for patient-oriented research, and even in the field of education. So some of you maybe may know that patients are increasingly engaged in developing the curriculum of healthcare professionals, in teaching healthcare professionals. And Caroline is a great example of this with her work at UBC. So in the past decade, we've really seen a shift from patients as research subjects to more active participants, collaborators, and partners. Recently, we did some work at the McMaster Health Forum about how can we create rapid learning health systems. So we looked at what was happening in Canada in every single province and territory to see what are the big assets and gaps in Canada if we're trying to develop rapid learning health system. And we saw that clearly patient engagement, but also citizen engagement, community engagement, family and caregiver engagements is really fundamental if we want rapid learning health systems. And we saw also that we currently have a lot of fantastic assets across the country in terms of patient citizen engagement and so on. We've seen in the past couple of years the emergence of organizations that are led by patients, like Patient Advisors Network. And I believe, well, Caroline is a member, but I may have seen in the attendance some founding members of Patient Advisors Network that you can find at patientadvisors.ca. So this is really unique, and it's been a great innovation in Canada. And we've seen new infrastructures to support patient engagement in the health system. If we just look at what's happening in Ontario with the Patient and Family Advisory Councils, we've seen work in the research system as well with the SPORE support units, the HT agency, Health Quality Ontario, and many other initiatives beyond Ontario. We've seen international collaborations as well. Many people working closely with the Patient Center for Oriented Research in the US, PCORI. We've seen collaborations with Involve, a group in the UK that tries to support researchers and patients engage in patient-oriented research. And also the James Lane Alliance that have supported many organizations in Canada and elsewhere to engage patients and the public in defining priorities for research. So there are currently many initiatives in the country, many initiatives that are sometimes done on their own, and we need to find ways to better connect these initiatives, better connect and leverage these assets if we want to move forward in terms of public and patient engagement. And you may see from that slide, which is really blurry, that the concepts are also quite blurry. This is a slide which shows the conceptual framework that was developed in the US by Kristen Carmen. And Kristen defined engagement using that framework, which shows a continuum of engagement ranging from consultation, involvement, and partnership and shared leadership. And what's interesting with that framework, Kristen Carmen also defined different domains of engagement. So in the direct care, at the organizational level, in designing programs and services, in governing organizations, but also at the policymaking level. And we could certainly add a few other domains, like I mentioned earlier, research, education. But what's interesting about this visual is that the concept of engagement can take many forms. We talked about patient engagement, family caregiver engagement, citizen engagement. So we may take different roles in different domains, different levels of engagement, and so on. So just to keep in mind that this is a very multifaceted concept that may take different forms in the system. So that sets the stage, and I'd like to now turn to Caroline, who's sitting in her hotel in Norway, Bergen, more specifically. And Caroline, would be interested if you could share some of your key insights based on your experience as a citizen patient in the past few years. And I know that your first insight was about the familiar policy foundation of patient and family-centered care, which is evolving towards patient-led care.
Thank you, FP. It's a real pleasure to join you today and to share these insights. You know, the challenge of coming up with a top 10 at first was quite stunning. I thought, how am I going to sort through all of my experiences and extract conclusions that are interesting to share with the audience we have today and the people who will listen in on our recording in the future. This first insight, it may not be entirely evident. We don't talk about the modalities of care very often changing. You know, we imagine the primary care physician and that therapeutic dyad with the patient. But I think what I've seen, and it goes back to the BMJ cover from May 2013 that you showed, The Patient Revolution. By hearing from patients in so many different roles and caregivers and families and communities, I think what we've seen tracking that involvement of the patient voice, and again, defining the patient very broadly, in tracking that involvement, we see a parallel in changing the therapeutic relationship so that we've gone from that hierarchical relationship of the doctor having the authority, the best patient being the compliant patient, to now swinging into a world where shared decision making is the goal in so many care settings, where the informed patient is engaged in making decisions about their care. And this is supported by many of the patient engagement processes that we have in place now at a system level. We see it playing out in the direct care environment, as with that matrix you just showed. What I see in the future is that the power of the patient perspective, the value of the insights that patients and caregivers, families and communities bring to care is swinging into patient-led care. This is also accompanied by the obvious fact that is becoming better recognized, that with patients with chronic condition, patients deliver care. Patients are making decisions among various resources in the healthcare system of what best supports them for their individual goals. So I think we're seeing increasingly individualized care, and we're watching an amazing evolution of our healthcare systems to cater to that individualized care planning and support and evaluation. It's a great challenge. This is supported by genomics research and a lot of other, the so-called personalized care, biomedical information and research that's coming into practice. So as I see in the future, I think what those of us who are patient advisors, and there are lots of us on this call today, we're helping carry that insight into what patients need to secure the best kind of care. And increasingly, I think we're going to see patient-led care for our values, what our values personally, individually are, how to realize that in publicly funded healthcare systems. It's going to be a challenge, it's complex, but I think ultimately incredibly rewarding for healthcare workers as well.
Thanks, Caroline. It's been, as I mentioned earlier, it's really been the era of partnership, but achieving meaningful partnerships is not easy. I know your second insight touches on the successes of patient partnerships and that it must align the different expectations from all the different partners, and we need to find a way to support their capacity. Can you elaborate on that a little bit?
Yeah, absolutely. So when we use the phrase patient engagement, I think most of us understand that these are partnerships between healthcare professionals and people from the patient, the user, the client of healthcare systems. The partnership is bringing expertise, respect, humility, and knowledge together to create better healthcare, safer healthcare, higher quality healthcare, better research, better education for next generation health professionals. So bringing together the medical model as well as the experiential model of healthcare is what's producing real advancement and more excellence in our healthcare system. But in order to have successful partnerships, the key and the point of this insight is that it's absolutely essential at the outset to align expectations. There's nothing that sours a partnership quicker than having failed expectations because they were not well defined at the outset. So that works on both sides of the partnership. The expectations that healthcare professionals or healthcare provider organizations may have about what the patient and caregiver is going to contribute to the partnership may be quite unrealistic. They may think, tick the box, and I think many of us have had this experience, tick the box, we've got a patient on our committee, this is going to transform healthcare in our setting. And of course it doesn't. It takes much more than that. As well, from a patient standpoint, to see an opportunity to participate in care improvement, to volunteer, and to think that this is going to be the silver bullet. I'm going to join this committee, I'm going to participate in this project, and magic is going to happen. That I'm going to be able to make a difference for other patients, which is often the motivation. If you come into the partnerships with expectations that are not well crafted, that are not shared and are well understood by all members of the partnership, it's not going to happen. Part of the success in partnership is supporting capacity development. Now, this may take the form of preparing health professionals to listen to patients and caregivers. That can be a very new role. And I'm not trying to diss point of care practitioners, but it's people, especially within organizations who are used to dealing professional to professional, to have contact and exposure to the patient point of view may be quite unfamiliar. So it's learning to listen, and that applies as well on the patient side. Many of us who come into this improvement work have no understanding of what the professional side is. And for me, 10 years ago, when I first began to ask questions about healthcare, I had no idea what was behind the curtain. And when the curtain was pushed aside and I got to get a glimpse of how healthcare happens, I was astonished. I had no idea, for example, that there was such a thing as patient safety, that this was a huge effort in healthcare providers. The idea that a patient might not be safe was a revelation. Now, I may have been quite naive, and people today may be more aware, but to understand what improvement science is, to look at monitoring and evaluation, much of this is invisible to the public. So providing capacity support to learn and become um, uh, engaged in creating joint knowledge takes effort. It takes an investment of resources, and it takes a commitment of senior leadership in healthcare organizations or in research environments or in educational institutions to support the success of the partnerships. They don't just happen because you recruit patients and try to plug them into a process that already exists.
Thanks. And it's interesting. I'm looking at your third insight. We've organized a lot of citizen panels at the McMaster Health Forum. We did also a lot of stakeholder dialogues on many health system issues. And one common theme across the panels and the dialogue is that often care is fragmented. There are silos in the system. So you see the role of patient advisors as potentially a connectors or bridges between these silos. Is that right?
You know, the role of patient advisor or patient partner or citizen patient, these are new roles, and there's a great appetite in healthcare now, as you've described, in many different venues for recruiting and engaging patients. Now, those of us who step forward I've noticed, are often incredibly curious and eager to learn. And we're interested in research. We're interested in health education. We're interested in practice improvement. We've never experienced health governance, and we're curious of what that's all about. So very often, patients who are involved in system level change are omnivores. They're not specialists. They're looking at learning more about how the sausage factory works that healthcare is, you know, coming into different venues and asking questions and learning and contributing from their lived experience, from our lived experience, from our insights as citizens, as taxpayers, as members of society who want to have great healthcare systems. So we may have experience in many different venues. On the other side, the healthcare professional is unlikely to have multiple experiences. So where I might be very interested in patient safety, which I am, I will meet people in many different settings who have an interest in patient safety. They may be researchers, they may be in practice improvement, they might be in the professional college of physicians and surgeons of a province. And I will learn about a research project in Newfoundland, Labrador that is really relevant to something that's happening in the Lower Mainland dealing with specialist physicians in quality improvement projects. I can connect up the researcher in Newfoundland with the specialist society in British Columbia. They would never learn about each other otherwise. But because of my curiosity and my agility, I can come in and out of projects. I'm not constrained by organization charts. I'm not constrained by a job description. I'm only constrained by the time available, my energy levels, my interest, my curiosity. So I'm also reading a lot on the side. One of the challenges for patient advisors is to learn, and it's not always easy to access information. But we do want to learn. We do want to learn more and more. And through wonderful tools like Twitter, which can connect us up with some brilliant healthcare researchers globally who tell us what to read, we can bring cutting edge developments in other countries, in other settings, in other parts of the country, in other parts of the cities we live in or in the provinces we live in. Bring those knowledge, bring that knowledge together, bring the attention to who some of the really great developers of innovation and new approaches to topics that interest us. We can bring them together. My own experience, because I've had the privilege of traveling to many countries, is connecting up researchers who very often are involved in exactly this, patient engagement, so that the leadership that Canada is showing in the world, and I do believe that we have some wonderful examples of high quality patient engagement. To bring that, for example, here to Norway, I'm in Bergen. I'll be talking, giving workshops and talking to health professionals in the University Hospital on Thursday and Friday this week. They're eager to learn from what we've innovated, and they are producing research and models that will inform work in Canada. Now, they would never come together in a conference. It's unlikely they will be publishing in peer-reviewed journals. So the chances of those two parties intersecting and being able to exchange insights and information is very unlikely. I'm not unique in this. I see it every day in British Columbia, where I live. I see it in Canada every time I get together with other patients, either virtually through networks like the Patient Advisors Network, or at conferences when I meet people that, again, otherwise I might not see. They have their networks. So when we're connecting up patients, we're connecting up we're creating networks of networks. Individual patient advisors have a network of clients, people they've worked with, healthcare settings they've worked with, professionals they've worked with, and they can connect up across domains, across geography, across settings of healthcare in a way I don't think anybody else can. And of course, the currency we have is enthusiasm. I think you can tell it in my voice. Anybody who's met me knows that that's what I trade in.
Excellent. Absolutely. And it's contagious. So thanks
Exactly.
for it. Turning to your fourth insight, you mentioned that strength in diversity is vital to achieve excellence in co-design. And I guess it could be co-design in research, program and services, and policies. I'm wondering about the strength in diversity and whether diversity sometimes can also be seen as a potential source of concern for researchers and policymakers and others who may see diversity as just making things more complicated. So could you talk a little bit about this strength in diversity?
Sure. Diversity is what Canada embraces. In healthcare, we have immense diversity, and it's really a national characteristic. We're very proud of our diversity in Canada in every respect. Healthcare has to address entire populations. It has to, and we believe in Canada so profoundly in equitable healthcare, so that this is pivotal for healthcare excellence. In patient engagement, one of the challenges we've had is that the earliest forms of patient engagement have really tried to attract what almost looks like a healthcare professional clone. And what I mean by that is the engagement design has been to meet the characteristics of healthcare system processes. So if I volunteer as an advisor to an improvement project in my health region, I'm expected to be available during working hours. I'm expected to be comfortable attending at a conference table, understanding what agendas are, having computer resources that can tap into webinars like today's webinar. And that's and there are many other aspects of these screens for recruiting patients. So we end up with a lot of patients who are retired, so they're available during the day, or they are not responsible for other people, for looking after other people during the day. They are able to travel to the site of healthcare deliberation, these various processes within our healthcare system. And they're comfortable in that business environment of agendas and minutes and boardrooms and training protocols and evaluation, comfortable with that kind of language. That's a very small part of the Canadian population.
Absolutely.
And it's also not characteristic of who's in the waiting room. So there is a very strong movement now to diversify patient advisors. And I think oftentimes it's an ill-advised campaign. because it's not about attacking who's stepping forward. It should be about developing different modalities of connecting with populations. And I would say the McMaster Health Forum Citizen Panel has modeled one way of accessing a rich diversity of the public, patients, people with lived experience in Ontario to participate in some of the deliberations, the health policy issues that you've taken on. There are many other examples. The BC Centre for Disease Control has a remarkable community engagement in Vancouver's downtown east side to look at disadvantaged populations who have lots of contacts with the healthcare system to better understand what that community of patients and caregivers and participants in our mosaic of our urban area in Vancouver, to understand their needs, to understand their assets and their contributions to better healthcare. So seeking diversity on the patient side is important. But what I would also say is that it's diversity on the healthcare professional side. We hear a lot about the struggle for physician engagement. So recruiting physicians as well as nurses and managers and informatics people and market surveyors, all those people in our projects strengthens the quality of the outcome of the project.
Perfect. And turning to your fifth insight, going upstream may be the surest transformation of culture. So we often talk about the need to change the culture to better support or champion patient engagement, citizen engagement, and so on. Could you elaborate on what you mean by going upstream?
Sure. So when we talk about healthcare culture, it's the environment, the sort of set of norms in which the healthcare professionals carry out their duties. And the movement, the patient revolution movement, has really shaken the roots of that culture, introducing laypersons who don't have the credentials, who don't have the traditional knowledge base. It's a different knowledge base, who have different skills, who come into the room, can be very disruptive to the assumptions that and the as I say, the behavior norms that constrain and support today's business as usual. To change culture is a tricky thing. You don't want to remove the confidence and remove the morale or assault the morale of healthcare professionals by saying you're doing it wrong. You've got to accept patients as being legitimate. Do it. It doesn't work that way. Collaboration is learned, and when I say go upstream, it's really through my experience with students and mid-career learners in the health professions, where I've seen the opportunity to enter a learning environment, whether it's undergraduate medical programs, nursing schools, or continuing professional development. But for patients to be able to enter that learning environment and introduce themselves as knowledgeable, as worthy of respect, as having something to offer in better understanding what great healthcare means, how the rubber hits the road, what the experience is like, how patients and members of society receive care and then put it to work in their own lives. How does medicine impact wellness and the patient-delivered care, which after all is most care. Patients and caregivers are the ones who deliver most healthcare services in society. That's a very disruptive idea. If that's introduced early on in health professional education or early on in career engagement in health partnerships, then I think we have a really great chance of changing culture in a way that's exciting and empowering for health professionals as well as for patients.
Perfect. I saw your sixth insight saying that patients and caregivers as advisors are becoming normalized. It's quite interesting because over the past few years, when I just started as a young graduate student, there was a lot of reforms. Back then, I was in Quebec, and each reform brought a different perspective. So one reform in the system would really focus on citizen engagement, and then the next reform would focus on patient or service user engagement. So there was this pendulum movement every reform, and it kind of showed that policymakers and health system leaders were really hesitating between patient and citizen engagement. But from what you see now is that engaging patient and caregivers as advisors, it's really becoming the norm. So it's a revolution that will stick. Is that right?
Well, yes and no. Yes, we're seeing lots of it. It seems that you can't be involved in any facet of healthcare without at least having a gesture talking about the relevance of patient and caregiver participation or citizen participation in some way. By becoming normalized, there's a huge danger that we normalize tick box. We become creatures of habit without investing the kind of curiosity and effort for each new wave of patients and caregivers, for the new participants that have been excluded in the past for some of these logistical reasons, the screens that are in those recruiting mechanisms, or the setting and the venue for partnership. So we can think that in a particular setting that we've got a great model for patient engagement. Let's just keep doing it more. And really be missing out on some of the creative development that's essential to better address the diversity of patient experiences and the diversity of contributions that patients and caregivers can provide within all these different settings and domains of healthcare. So it's a bit of a double-edged sword. Yeah, it's great to be talking about this as just the way we do things. But if we kind of toss it off as, well, we know how to do it, off to the races, we end up with a very narrow version of what the full, rich contribution that Canadian society can make to the shape of healthcare and the future of healthcare. Just as I was talking about patient-led care, I think that there's an emerging patient-led creativity in the kind of contribution that patients and caregivers can provide. And we're seeing already, for example, in research, patient principal investigators. Now, this is tricky stuff, and I would say the research establishment is certainly, I mean, this is brand new and it's not entirely comfortable, but co-lead investigators, collaborators at a very high level of people who come with a lived experience and a vast experiential base and theory that is homegrown with academically trained methodologists and informatics experts, people who are involved in e-health, for example, with lots of technical background. That partnership can be incredibly creative and brilliant. And in some cases, I think it's the only way to get into the future in a way that honors what Canadian citizens deserve in their healthcare systems. To achieve the very best, I think we need to tap into the creativity from everyone who's in the room and expand the diversity of who's in the room. So if we get too complacent about, I guess, believing the headlines, that we do great patient and caregiver partnerships, I think we'll really lose out on the full potential that is going to carry us into the future with great healthcare and healthcare that meets the needs of our society.
Perfect. Thank you, Caroline. And I was looking at your 17 insights talking about the motivation and life cycle of the patient advisors. You indicated that it requires study to better manage this essential health human resources. It's a very interesting perspective. Could you elaborate on that and talk about how motivations may evolve over time for the patient advisor?
This is fascinating to me, and it's the latest greatest idea that I have for a sort of undiscovered part of patient engagement, and it really builds off this idea of normalizing. We have increasingly made a dominating part of Canadian healthcare research, the SPORE, the Strategy for Patient-Oriented Research, to have patients involved in that research activity. It would be fair to say there's a whole realm of health services and health policy research that no longer can be done without having patients involved. So I think the argument can be made, for example, in that area of research, that patients are an essential element of the human resources necessary for research. Now, you could say the same thing about practice improvement, and increasingly there are areas of health professional education that have to be done with health mentors, partnering up people with chronic conditions with students who are studying to be health practitioners. So this is my argument for saying the patient, the caregiver, is becoming an essential health human resource. And we know nothing about this resource. We don't really understand why people step forward and do this stuff. I mean, I can tell you anecdotally why I do, and I'm sure many of the people on the call who are also patient advisors can identify their individual motivation. But to understand more broadly in Canadian society, what is it that gets us out of the door and into health professional environments where it's often uncomfortable, and we have to learn how to dance with that in that professional environment. Why do we do it? What do we get out of it? And how long can we do it? What sustains us? How do we learn? When we have terrible experiences in partnership, when we are the tick box, what gives us either motivation to say, well, that's the end of my time as a patient advisor, or to say, I'm going back. I'm going to show them we can do better than that. So to better understand the career path, if you like, of these amazing Canadian citizens who step forward and say, I want to be a part of healthcare improvement, to understand that will be essential for sustaining that part of health human resources. Unless we understand what the motivations are, the rewards, the incentives, the causes of burnout. And I can tell you from personal experience, there are certain healthcare settings that I know to steer clear of, because my own lived experience says it's too upsetting. My emotions are too raw. I experience a kind of post-traumatic stress, and I need to step away from that. But we don't have anything more than my anecdote now. So if we're serious about saying we've got to have patient partners, we've got to have caregiver partners to create better healthcare, we really should know more about what it is to do that work, therefore how to support it, and how to really enhance the experience of patient advisors to get the very best for healthcare improvement out of them.
That's very interesting, because I know there's a lot of studies where we try to shadow healthcare professionals to see how they manage their professional work. So that we may follow nurses to see how they do their work, the challenges they face. Perhaps we need some of those initiatives, the shadowing initiatives for patient advisors, to learn about what they do, see how their motivations and are changing over time, the challenges they face, and so on. So it's quite an interesting idea for a research project.
Well, let me give you a hot tip that's fresh from northern Norway, way 500 kilometers north of the Arctic Circle in the last few days. I met two, count them, two medical anthropologists Now, what a brilliant, I don't know if Canada has medical anthropologists. I'll find out because I'm curious. But medical anthropologists who are involved with research on that involves patient partnerships, that involves patient-reported outcomes. They're very interested in sort of what that patient experience is from anthropological standpoint. Well, that's kind of what I'm suggesting here.
Exactly. And I see someone just mentioned on the chat box that there are indeed medical anthropologists in Canada. So perhaps we need to bring in some on board to explore this issue in Canada. That's very interesting.
Yeah, I want them to look at the patient advisor. I think that this is, I think it's fascinating.
Perfect. And then it's a nice lead through the next insight, but looking more from the professional perspective, so that you indicated that patient partnership serves professional satisfactions and can also counters burnout. Can you elaborate on that?
Sure. When I first came into healthcare, one of the things that astonished me was how much of the job environment for point of care workers seemed perfectly designed for burnout. You could not create a more challenging and disappointing structure around people who seek healthcare professions because they want to help people. We disconnect the outcome from the involvement of the patient. So the operating room staff, the people who work in the operating room, never find out if that patient ever recovered function. Did the surgery succeed in helping that person live a better life? We don't have feedback loops. So what I see in good patient partnership and successful patient partnership is a way of reconnecting healthcare professionals with people who value great quality care, and to have those partnerships be mutually supportive, to share understanding, and to respect the successes in a very human way, to work through challenges, to find solutions in ways that really enhances the human relationships that are foundational for healthcare. I oftentimes say that without relationships, there is no healthcare, and strengthening relationships is really the route to strengthening the quality of healthcare. So I think just on a very simple level, partnering patients with health professionals to achieve tasks together, to succeed in tasks, is in itself a counter to burnout and can contribute to professional satisfaction in a way that very, very little else can with our increasingly fragmented and specialized and complex healthcare system.
Perfect. Now turning to your ninth insight, you indicated that patient and family collaborators are connecting up in peer networks to develop capacities and skills. So they are proactively getting together to develop their capacity and skills. And I mentioned earlier, and you mentioned earlier, Patient Advisors Network. I know there are patient academies being created across the world. Many organizations that are led by patients are emerging. So it's fantastic to see that patients and family collaborators are getting very proactive in this area.
Well, this comes through trying to fill a gap. It sounds wonderful, but it really comes from the struggle that citizens have in learning about healthcare, to learning about practice improvement, learning about research, learning about professional education. And it oftentimes almost always, our engagements are episodic. We're brought in for one focus group. We're brought in for a 6-week project. We're brought in for a 6-month project. But between engagements, there is no support. And mostly, we volunteer as individuals. We come into a project really on our own mettle, on our own confidence. So just as with healthcare professionals who gather for conferences and workshops and collaborations, patient and family advisors, collaborators, partners also need to meet up part of it is just finding out that other people are sharing some of the same experiences you are. Being able to ask questions and have discussions about issues of mutual concern and be able to benefit from others' experience. Um, I look at the conference schedule, which is so busy across Canada, with people in so many cross-cutting so many different ways through topics, through roles, through geography, coming together to share experiences, to talk about the great successes and to challenge others, to provide new answers, to hear the latest, greatest ideas that are beginning to transform their area. Patients and families want to be a part of that too. We're just as committed to the tasks that we're invited to participate in, but the barriers are very high. I think there's no doubt that it's important to provide incentive registration fees for students, but it's very rare in Canada still to have incentive or dispensed a free registration for those of us who volunteer without being paid, without being seeking a career and future income, but just want to learn, and we want to network with each other and network with professionals. So the Patient Advisors Network is an expression nationally of this great movement in every province, in every part of the country, of patients and caregivers who are anxious to meet each other and to share knowledge and to share skills and expertise and support and mentorship in a way that there's no other structure to do it. And when we founded PAN, it was very important for us to have it be peer-led and independent. We didn't want to be under the thumb of any organization. We wanted this to be a genuine grassroots and accountable organization to the members. So I'm very pleased with how rapidly the Patient Advisors Network is growing. We have something over 150 members now, right across the country. It's a bilingual website because we believe it has to be nationally accessible, and it's virtual and it's free. There is no membership charge, and I do believe that it's essential for capacity development and building leadership. And I'm thrilled with that particular example. Within provinces like British Columbia with the Patient Voices Network, that's another provincially run network of patient and family collaborators. And I think in many other provinces, Ontario has mechanisms for patients to meet up to within health authorities, regional health authorities. There are very often ways to meet other people who are doing work within the province. In Saskatchewan, within the province of Nova Scotia, there are some of these mechanisms. So it's because we care. We care about doing a better job, and this is one way we can develop our abilities.
Thanks, Caroline. And I saw your last insight, and I was wondering if you were nostalgic, being in Norway, far away from home. And I see that your last insight was that Canada has something unique and precious, the public's altruistic generosity towards healthcare.
This is really fundamental from the very beginning, FP. It's not got to do with being in Norway, but it really does have to do with my surprise as I've traveled to see that what I thought was common, the willingness of Canadians to participate in something for the common good. We see it all the time. It's pulling over on the shoulder of the highway in winter when you see a car parked to make sure everyone's okay. We have in our country a well of goodwill and concern about everybody's well-being. And that it does sound romantic and nostalgic, but I think it's very real. And as I travel, I see it writ large. And I don't want to make examples of countries that struggle, but many countries have a terrible time finding volunteers because it's not in the national culture. It's not in the traditions of those societies to step forward. And when I say I believe it's precious, I also think it's vulnerable. If we abuse the patient revolution, if we are not successful in supporting the members of the Canadian public who step into healthcare, a very challenging and traditionally hierarchical environment, it's life and death. The experiences of the citizens of the public who come in as volunteers, as patients, and as caregivers, they have experienced life and death. So this is profound. To contribute to other people's welfare with that knowledge and that background is very moving to me. It is about Canadian citizenship. It is about our aspirations for our country, our optimism about what we can do as a nation, and our often undue, unjustified loyalty to healthcare. You know, here is Tommy Douglas, the most admired Canadian. And yet, you know, when we come into our healthcare experiences, we're oftentimes shocked that the healthcare system isn't as good as we expected. I think we have the opportunity to spoil the public's confidence in healthcare, and we also have the opportunity to really invigorate and enlighten and strengthen the public's ability to actually make a difference in improving healthcare as individual acts of participation. I think we do have something precious, and the more I travel, the more I appreciate the sentiment that Canadians have for each other.
Thank you so much, Caroline. Thank you so much for your insights. We still have a few minutes, but I'm sure Caroline would love to continue the conversation after and in following weeks. So she is providing here her contact details at UBC. So caroline.canfield@ubc.ca. So please don't hesitate to send a quick email to Caroline to continue the conversation about this. And turning now to the group, I'd like to open up the conversation. If you have your own insights that you'd like to share, if you have specific questions for Caroline about her insights or her experiences, please do so using the chat box, which is at the lower right side of your screen. You can also tweet using the hashtag MHFTop10 or at McMaster Forum. So what are your insights, and which insights from Caroline may have resonated with you the most? Let's open up the call. But in the meantime, while we wait for questions, I have a quick question for you, Caroline. I'm really excited about your role as an adjunct professor at UBC. So I've known patient partners who had struggled with being fully recognized within their research organizations or within the university with which they were affiliated. But what it is to become an adjunct professor when you're a citizen patient? What is it about?
Well, it was a bit of a miracle. It's very much the exception, and I very much hope that it's a precedent for the future, and that other universities across the country, especially the medical schools, begin to recognize the contribution that we can make within curriculum. So I expressed interest in a role in the university and was offered a desk, and then I expressed interest in having a library card and was told, well, we'll just make you faculty, and I never knew it was that easy. So I wanted a library card to read peer-reviewed journals where the pay barrier is too high. But in fact, what I've done with the privilege of, and I don't have pay, this is an appointment without pay to it, but it gives me access to committees about curriculum reform, to governance issues. I get to sit on and I've I guess earned the ability, but by credibility, but I get to sit on the admissions committee to the medical training program, the MD undergraduate program at UBC. It's Canada's largest generator of physicians, and and the idea of being able to influence what kinds of candidates actually get in is brilliant. I mean, this is where it shouldn't just be me. We should have this in every medical school across the country and have discussions about what, from a pedagogic standpoint, what are the characteristics we want to look for in candidates? And I think a national strategy would be terrific that would involve a public dialogue. So I love the idea of being a patient, being a citizen within the university. I think it helps fulfill the university's ambition to have outreach into the community, and it also takes advantage of the specialized knowledge that all of us patient advisors have.
Thank you, Caroline. And I see that there's already a few questions in the chat box. So the first one from the McMaster Health Forum, I believe it's Stephen or some other colleagues at the forum, asking, would the panel be able to share insights on how to assess the readiness of health systems for citizen engagement? So that's an interesting question, and perhaps so we do know a little bit how to assess our readiness to engage, and there's been some work done by Julia Abelson at Mac. Actually, Julia led some research and tried to develop some evaluation framework, which is the patient and public engagement evaluation tool, which is publicly available on the McMaster University websites. And the tool can be used by health system organizations to assess their readiness to engage to some extent. So we do know about some tools existing to assess our own readiness to engage, and also perhaps how can the health system prepare to engage citizens in healthcare policy development. That's very interesting. So in a way, I guess it's not just preparing to engage citizens. We need the system to adapt and develop new mechanisms to engage citizens, ways of doing things.
I think the Canadian Foundation for Healthcare Improvement has some really powerful work on engagement-ready organizations. What health organizations need to do to really prepare to succeed in supporting patient engagement. And there's a lot of material worldwide. There's a lot of material across Canada to address these issues of capacity development within the healthcare systems. I'm very interested in capacity development for citizen patients because I think that's where there are few resources devoted. In fact, we kind of do it ourselves. No budget, but we do it because we love it. And I think that's an area for great potential and growth and support.
And I see a question from Julianne who asks, do you have any advice for funding organizations wanting to engage more with patients? Caroline, do you have any suggestions?
Well, I'm wondering what funding organizations are, because so on the one hand, what I see is there are many health providers and health organizations that are pressed in their budgets. They want to expand their patient engagement, and occasionally cost can be a barrier. I think that there's a great opportunity. I mean, this is going to sound self-serving, but I think there's a great opportunity for philanthropy to support the citizen patients. We have many people, many families who experience healthcare failures. And I do think that the philanthropic community in Canada, many of those family foundations would give their right arm to have an opportunity to support organizations that are supporting the patient voice and capacity development and leadership. Funding organizations at a national level have struggled to figure out how to support patients in research, for example. We have the SPORE framework, but it has yet to come up with ways of funding the patients who are increasingly becoming quasi-researchers or full researchers unless they're built into the budget at the outset. So we're learning as we go along, but I'm not sure I understand the question entirely.
Perhaps. I don't know if the person, I think it was Julien, if you have any details about what you mean by funding organizations, and if you want to put that in the chat box, we can address that in a moment. I see two questions from Richard Edwards asking, what's been the experience with the new hospital accreditation standards regarding patient and family engagement? And how seriously are the expectations being taken by hospitals? Any experience with that, Caroline?
Well, I think hospitals are taking it very seriously, and the extent to which they're succeeding, I'm not qualified to make generalizations. I know Accreditation Canada has patient partnerships that are developing the standards, and also brilliantly, Accreditation Canada has taken on the role of patients on the, what are they called? I don't have the right word in my mind. It's not an inspectorate, but when the accreditors arrive in your hospital and they're assessing your performance, there are now patients with clipboards too, and they are trained and they're partnering with the usual people who do the surveys. I think that's the right word, surveyors.
Yes.
And so Accreditation Canada and Health Standards Organization are working in partnership with patients to develop the standards and to develop expertise among citizen patients, patient advisors, patient and caregivers to do the survey work in partnership with professionals. To the extent to which they're finding excellence, I don't know, and that's my ignorance. It may be well reported, but I'm just not aware of it.
Perfect. And perhaps one last question from Bev. Bev is asking you, Caroline, whether you could elaborate a bit about something you mentioned about patient burnout and knowing that you have a very busy schedule, you're very engaged, and that many patient partners are starting to drop off due to the burnout. Could you talk about that a little bit?
Yeah, it's I think SPORE is one of the best illustrations of the cynical use of tick boxes. And I can't tell you how many times and I'm not unique in this, I'm one of hundreds, if not thousands, of Canadian patient volunteers, patient partners, who have received emails on a Thursday afternoon saying, May I use your name and add it to my research proposal? I can send you the draft. The deadline's Monday. We're still rewriting it on the weekend. Would you write a letter of support?
Yeah.
And it's a wrenching experience to be offered a role in a research project where you really care about the content and realize right at the beginning that you're marginalized, that you're not being respected, you're not contributing to the project design, and you're being abused. Another example is the patient story. How many of us who have had caregiver and patient first person experiences that have been our motivations to get involved? We've been asked to address a conference or a workshop. We get up to the microphone. We tell our story oftentimes of care failures or care gaps, and the letdown afterwards of, so what? I've just exposed my emotional vulnerabilities, my tragedy. I've relived it in front of an audience. What difference did that make? So these kinds of experiences are pretty rough. And it becomes compounded with our expertise and our devotion to excellence as we develop greater skills to come into projects where we can't do enough. We realize there are gaps and our passion is so great, there aren't enough hours in the day. We can't fill all the demand when we see so many interesting roles to play. And there isn't any career support for us. We don't have career counselors. We don't have mentors in any formal way unless we invent it ourselves to help us cope with these demands. If we get involved in a project that has higher expectations of us than we think we can deliver, how do we go about negotiating support? It can be a very lonely and a very rough challenge to our sincere dedication to the task at hand. And to fail when we've had personal experiences that are the driving force for us to continue. When we fail in a partnership, it's a very personal experience, and there's not too many people we can go to unless our network is pretty strong and say, geez, I really tried my best and it was a disaster. What do I do next? How do I recover? How do I, and in my, so an example for me, I might be forced into a situation where I say to my husband in my mind, how can I face that I failed in this project that I thought would address some of the gaps that led to your death, and I blew it. It didn't work. So I think that the stress and strain of all kinds of normal work is writ large for us because we're on our own.
Thank you so much, Caroline. Thanks for sharing your insights today. As a citizen patient, it was a pleasure to listen to your stories and experiences. So thank you very much. And I'll turn to Stephen at the forum.
Yeah. Well, thanks, FP. I just wanted to say thanks again to Caroline and to yourself, FP, for a really interesting discussion today. Some really great insights on patient engagement in Canada, but equally applicable around the world. I just wanted to reiterate as well, I know Carolyn left her email address, so for people that want to continue the discussion, you can certainly follow up with her or us at the McMaster Health Forum at forum@mcmaster.ca. Or on Twitter, either through us at McMaster Forum, or FP is also on Twitter at Forum CDN Health. So I'm sure he'd be happy to answer questions and continue the discussion as well. So again, thanks to both of our panelists for joining us today. A great discussion, and hopefully a conversation that will continue. Thanks again.
Thank you, everyone. Thank you very much.
Thank you.